Good evening, everyone. Welcome to yet another dearly awaited OSCE session of the White Army. We are blessed to have Dr.Archith Boloor, sir, additional professor at KMC Mangalore as our mentor. Sir is renowned for the leading books, Exam Preparatory Manual for Medicine for Undergraduates, and An Insider's Guide to Clinical Medicine. We are privileged to have you with us, sir. We also welcome all the active members to this session. With Sir's kind permission, let us begin.
Good evening, all. I think the slides are visible.
Yes, sir.
Okay, then I think we'll proceed. I think hopefully today I'll be able to finish whatever was expected from the OSCE session. So in the past sessions, I think as we have discussed about the ECGs, the images, the X-rays, the clinical scenarios. So I think two sections that are remaining as of now is the instruments and the ABG and the procedures that are commonly asked for you in your vivas and the OSCEs. So let's begin that. So again, like the sessions that we have had earlier, I would expect people to interact and that's how we will proceed. So let's begin. Okay, so this is the first image of the procedure, a very common procedure that we do. All of you would have done it. So this is ascitic paracentesis. So the first thing is, where do you do the ascitic paracentesis? What's the site?
Left sided, preferred more than right.
Okay, why is that left sided?
Why
Left side is preferred more than right?
Muscles side.
It's not related to the vessels. Anything more specific?
Sigmoid colon is retroperitoneum, so colon is not.
Okay, it's the cecum that is there on the right side that is there, which generally the patients who are on ascites, I mean, CLD patients generally would be on lactulose and other things. So they would have some gaseous distension, and on the right side you have the cecum that is there. So that's why the left side is a preferred site compared to right. You can do it on right. So where do you do it actually, the point?
Between between medial 2/3 and lateral 1/3, or the maximum dullness. Between umbilicus and
spino-umbilical line.
Okay, yes, spino-umbilical line that you're saying. I think as per the textbooks, I think it is above the ASIS, that is your anterior superior iliac spine. That's the landmark you're taking. Around 4 to 5 centimeters above and medial, they say, from the ASIS. That would, I mean, roughly come to around your, as you said, the medial third and the lateral medial 2/3 and the lateral third of the spino-umbilical line. So you're going to do it there. Very importantly, you have to make sure that there are no vessels in that part. So the veins that are there, you have to be very sure that the veins are not tortuous or something. So you have to avoid that. And then you're going to do the ascitic fluid sampling. And then what are the tests that we do with the ascitic fluid? So what are the various tests that you'll order for?
albumin, protein,
yes.
total count, differential count.
Total count, differential count.
ADA.
Then ADA, okay, ADA if you suspect tuberculosis.
Then if SPP suspecting infection, then culture, gram stain.
Okay, gram stain and culture. How do you send ascitic fluid culture? How do you send the ascitic fluid culture?
10 ml in blood culture bottles.
Okay, it has to be on the spot, inoculated in the blood culture bottle. That's very important. It should not be sent in any other container and later. It is on the spot. You are supposed to put it into the blood culture bottle. Okay, any other investigations in particular scenarios you can do it? Other than these?
Cytology.
Yes. Amylase. Yeah, cytology can be done. Yes, cytology can be done. How do you send cytology sample?
50 to 100 ml we should send, and then it has to be centrifuged and then look for cells.
Okay, so anything specific you will add to that 100 ml?
Heparin.
Heparin, okay. a little bit of heparin that's required. Not very much. You do a little bit of, maybe a few drops of heparin is sufficient for a 100 ml bottle that you would be sending. Amylase you can do for the tuberculosis if you're suspecting, as you said, you can do the AFB, ADA, gene expert can be done from that. Malignant cytology I've already said, and some other times you could do the other tests also. Okay, the most common question they ask you is, what is SAG? What is the definition of SAG and what's the relevance of SAG? Yes?
SAG stands for serum ascites albumin gradient, sir. It
Okay,
helps
serum ascites
differentiate.
albumin gradient, correct?
So it helps us to differentiate between portal hypertensive causes and non-portal hypertensive cause for ascites.
Okay.
More than 1.1, it would indicate a portal hypertensive cause.
So more than 1.1 SAG would indicate a portal hypertension as a cause. So the earlier the words which were used for any fluid for that matter, they used to call it as either transudate or exudate. Now we do not use those words. Now we call it as high SAG or low SAG ascites. So what are the other causes of high SAG ascites? Portal hypertension is more than 1.1. What are the other causes of high SAG ascites?
Late Buddhari.
Okay, acute Buddhari. Then
advanced malignancy.
Other commonest cause?
Heart failures.
Heart failure. So heart failure is the second most important cause which could produce the ascites and which would be high SAG ascites. So how do you differentiate whether it is a high SAG due to cirrhosis, portal hypertension, or a high SAG due to heart failure?
Protein must be
protein.
Okay, you will have to check the albumin. So you check for the albumin or the protein. So if it is due to the cirrhosis of liver or the portal hypertension, then it will be less than 2.5. So the total protein less than 2.5, it is more suggestive of a cirrhosis. Whereas if the total protein is more than that, that would be suggestive of a cardiac cause of cardiac failure producing the ascites, that is SAG, which is high. What are the causes of low SAG ascites?
TB, peritonitis.
Yes.
Peritoneal carcinomatosis.
Peritoneal carcinomatosis, correct. Other causes? Malignant, you said. TB, peritonitis, you said. You could get it in pancreatitis. Yes, you could get it in pancreatitis. Sometimes you could get the infections, the other infections, like you would have a peritonitis due to some organism, secondary bacterial peritonitis. Yes, secondary bacterial peritonitis. All of them are the causes of a low SAG ascites. Low SAG ascites, that is important. Okay. What is corrected SAG? What is corrected
SAG
SAG?
multiplied by 0.16 multiplied by serum globulin in grams per deciliter plus 2.5.
Okay, so this is corrected for the globulin levels. So if certain conditions, the globulin levels could be also elevated. So you require to correct it for the globulin, and that's where you do the corrected SAG, not necessary in all the conditions. Okay. So these are the common things about SAG that you have to know. And the next thing they ask you is, how do you diagnose spontaneous bacterial peritonitis? How do you diagnose spontaneous bacterial peritonitis?
Absolute neutrophil count less than 250.
Okay,
More than
less than or
More
more?
than 250.
More than
250.
More than
Correct.
250.
Second criteria?
It would be no polymicrobial, monomicrobial.
It should be monomicrobial.
Yes.
Single organism has to be grown. The third criteria? There should not be any intra-abdominal source of infection. So these are the three criteria that have to be met to diagnose spontaneous bacterial peritonitis. Neutrophil count of more than 250, total count more than 500. Single culture, single organism has to be grown, and most often the organism that is grown is
E. coli.
E. coli.
E. coli is the most common organism that is caused by that. And there should not be any intra-abdominal source of infection. All three, if it is met, we call it as spontaneous bacterial peritonitis. What are the other types of bactericidis you know of? What are the other types of bactericidis? Other than
Culture
SBP, what are
negative.
the other?
Culture negative
Yes, you have something
neutrocytic.
called as culture negative neutrocytic ascites. That's one. Yes. Then
Polymicrobial. Polymicrobial bactericidis.
polymicrobial bactericidis, correct. Then
Monomicrobial non-neutrocytic.
okay, monomicrobial but not neutrocytic. Same, the three criteria only has to be met only the combinations you change it. So if it is culture negative but neutrocytic, you call it as culture negative neutrocytic ascites. If it is monomicrobial but non-neutrocytic, that is called as monomicrobial non-neutrocytic bactericidis. Then as you said, it could be a polymicrobial or a polymicrobial bactericidis could be there. And sometimes you can have secondary bacterial peritonitis. So these are the common definitions that you have to know about the thing. Okay. How do you treat spontaneous bacterial peritonitis?
Third generation cephalosporin.
Yes. What's the dose and what's the drug?
Ceftazidime can be given, sir. 2 gram
Not
IV.
ceftazidime. Not ceftazidime. What
Ceftazidime.
we use is
Cefotaxime.
cefotaxime. Okay, and please remember the dose. The dose is 2
1
grams
gram,
twice
2
daily. 2 grams twice daily is the dose of cefotaxime. Has to be given for 5 to 7 days. What are the drugs that are used for the prophylaxis of SBP?
Fluoroquinolones, Norflox.
Okay, norfloxacin. Yes, then that's a drug that we use in India. What is the one which is recommended in the West? Rifaximin is not specifically for that. Rifaximin is not specifically for that. Rifaximin,
sir.
no, Ciplox. Quinolones are not recommended in the West. In India, still we.
Septran.
Yes, it is the Septran. What is the combination? Cotrimoxazole, isn't it? Trimethoprim sulfamethoxazole. That is the drug that is recommended for the prophylaxis of SBP world over. Okay, but in India we still use quinolones, norfloxacin we use. Okay, so that is the treatment of and prophylaxis for SBP. Okay, other than SBP, any other condition we use norfloxacin prophylaxis in a patient with cirrhosis?
Hepatic encephalopathy.
Okay, if the patient has already developed hepatic encephalopathy, possibly we may use it. That is plus minus. Anything else? If they have had
After
GI bleed
bleed.
in the past. Okay, if they have had GI bleed in the past, such patients also are prone to develop this complication, so they are put on this. Okay, so that's about the ascitic fluid, the general questions they ask you about the procedure and the complications. What are the complications that can ensue? What are the complications of this procedure?
Persistent leak, hemorrhage.
Okay, you could get
Bowel
hemorrhages
perfusion.
there. You can introduce infection. Very important is gross ascites when you have, and if you have done, if you tapped a lot, then you could get hemodynamic instability. What we call it as a large volume paracentesis, where we are removing more than 5 liters. That can precipitate encephalopathy also. You could get something called as a persistent ascites fluid leak. So because the tract that could be formed there, you could get leak from there and you could get secondary infection there. And as you said, patients can have coagulopathy and they can develop some sort of a ecchymosis at that part. So those could be the common complications. Important is infection and hepatic encephalopathy precipitating. Those are the two important complications that you have to know about. Okay, so what is this?
Lumbar
Possibly
puncture needle.
Yeah, so this is the spinal needle or the lumbar puncture needle. So one of the commonest instrument that is kept for you, and a lot of questions are asked on this. So the common questions that they ask you is, what are the indications and what are the contraindications? So what are the indications for the procedure?
Meningitis.
Okay, so for the diagnostic indications, as you said, meningitis, correct. What are the other
Encephalitis.
diagnostic indications?
Encephalitis.
Encephalitis, correct. Then
acute leukemia or lymphoma, sir.
Why do you want to do a CSF in them?
If it's a primary or metastatic, to differentiate that.
Okay. Sometimes maybe if you're suspecting a leukemic meningitis. Again, that is meningitis only. Any cause of meningitis you would want to look for. Any other indications? Yes, GB
Multiple
syndrome, very
sclerosis.
important. GB syndrome, one of the important diagnostic indications, correct? Then multiple sclerosis, as you said. Multiple
Subarachnoid
sclerosis
hemorrhage.
or subarachnoid hemorrhage, though it's an indication, we do not do it. For SAH, we have better investigation. Just by CSF, we don't get anything. We just see the blood there. So it's okay. It's, yeah. What else?
PO.
NPH to remove
NPH. Okay, diagnostic indications. Okay, when you have PO, sometimes maybe. Okay, what are the therapeutic indications?
IH.
Therapeutic indications. Most important.
Anesthesia.
NPH.
Anesthesia, isn't it? Anesthesia and epidural analgesia that you give during the delivery. So that's one thing. Then you could have intratracheal drugs that can be given. What is the most important one which is used?
Methotrexate.
Methotrexate for acute leukemias. Okay. And the other one which we see in elderly patients where we use a therapeutic CSF tap is
NPH.
NPH. Okay. Normal pressure hydrocephalus. Normal pressure hydrocephalus, that's for which we use for that's a very important and a very common thing where we remove around 50 ml of CSF maybe alternate days 3 to 5 times, and that would cause significant improvement in the patient. So these are the common indications. Okay, what are the contraindications? Absolute contraindication is
Hemophilia.
Thrombocytopenia.
okay, they are all relative. The most
Raised
important
ICT.
raised ICT is the most important as absolute contraindication. Yes, the site, if it is not accessible, if there are any skeletal deformities or an infection at the site, possibly you won't be able to do it. If the patient is hemodynamically not stable, then CSF analysis is not. Coagulopathy definitely is a contraindication, as well as yes, the patient not giving consent. Yes, non-consenting patient is an absolute contraindication. You cannot do the procedure itself. The relative contraindications, thrombocytopenia and the skeletal deformities may be a relative. You can do it a little lower level, or you can do sometimes the cisternal puncture can be done. So these are the contraindications that you do it. Okay. What's the site of lumbar puncture? What's the site of lumbar puncture?
between L3,
L3,
L4.
L4.
Okay, anything after below L2? L2 is where the spinal cord ends.
Below
So
L2.
ideally you do it at L3, L4. That's where you can do it. And you can do it up to L2, L3, L3, L4. You can do it. Okay. So you know how to identify, or if you would have done the procedure also. Okay. The next question they ask you is, what are the structures that is preventing, or the structures that you would pass through before you reach the space? What are the various structures that you pass?
Skin to ligamentum flavum.
First ligamentum flavum, straight.
No,
Yes,
sir.
first
From
skin subcutaneous tissue, supraspinous ligament,
supraspinatus, infraspinatus,
interspinous ligament,
Yes. Then
ligamentum flavum, dura mater, arachnoid.
okay. So that's the layers that you're going to puncture. So starting from the skin, the subcutaneous, then you have the supraspinous, then you have the interspinous ligament, and then you're going to come to the subarachnoid space, subdural, and then you're reaching the subarachnoid space. So that's the layers that you're going to come down from outside to that. And always, you know, the bevel has to be facing the roof of the patient. And the first thing that you have to do once you're done, once you're in the space is
Pressure.
yeah, measure the pressure. I don't know how many of you have done it practically, but you have to know what's the normal pressure. What's the normal CSF pressure?
100 to 150 mm of mercury, sir.
Okay, 100 to 150 millimeters of
Water.
centimeters of water. That is 10 to 20 centimeters of water. It's millimeters of mercury. It is yeah. So that's the normal pressure that you see there. Water is almost, you know, it is very less, 10 to 25. What we measure, we don't use mercury. We're using a graduated tube and water. You don't, it doesn't, the tube is not a very big tube that we use. We use a maybe around 30 to 40 gradations only, centimeters will be there in that. So you're measuring it in water. So up to around 20 to 25. 25 centimeters is normal. Anything more than that is elevated. Okay. And then you're going to do all the evaluation of each of them. Very importantly, they'll ask you the features. All of you know that the test that we do, the glucose, the protein, the cell count, and the cell type. That's what we do that in the various conditions. You'll have various specific patterns. The lymphocytic meningitis, they are the viral, the tubercular, and the chronic fungal meningitis, as well as the syphilitic meningitis. These are the lymphocytic. The neutrophilic is the pyogenic meningitis that you could have. Again, please remember, whenever you do the lumbar puncture, you are simultaneously measuring the sugar, because your sugar levels are up to 2/3 of the blood sugar. Up to 2/3 of the blood sugar is what you expect it to be there, normal. If it is lesser than that, that is decreased. Okay. So what is the finding that you get in case of GB syndrome?
Albuminocytological dissociation.
Okay, why do you get that? Why is that albuminocytological dissociation? What do you mean by that, and why do you get that?
Due to demyelination, protein are more in the CSF.
Okay, so there is a demyelination of what?
Nerves will leak the proteins.
Nerves is
Nerves
where
that are linked to
CSF is
protein.
where.
Root radicals.
It's the radicals. It's not the nerves. GB syndrome is not the nerves. It is the radicals which is getting demyelinated, and radicals are going to increase the protein. Okay. So there are no cells. So only the protein that is elevated. What are the other conditions where you can get this?
Subarachnoid hemorrhage.
Subarachnoid hemorrhage, you won't have
Multiple
protein that is.
sclerosis.
You will get it in other demyelinating conditions also. You might get it in other demyelinating conditions also, like multiple sclerosis. Cells may not be there. Okay. Which GB syndrome, if you do not have albuminocytological, you have CSF pleocytosis, cells in the CSF. Which condition? GB syndrome, but cells are there in the CSF. Normally in GB syndrome, we do not find any cells. We find only 0 to 5 normal. Supposedly 50 cells are there, but still it is GB syndrome. What is your diagnosis? Anyone? In which group of patients? Hopefully you got the question. Normally in GB syndrome, we do not find CSF pleocytosis. That means we do not find cells in the CSF. So in which condition GB syndrome will we still have cells in the CSF?
MFS variant.
Miller-Fisher variant of GB syndrome.
No, not in Miller-Fisher. Miller-Fisher will not have it. It's a very
Acute.
specific thing.
Pure axonal.
No. Which
HIV
GB syndrome?
associated.
HIV associated. Very important. Please remember, in a GB syndrome, if you find cells in the CSF, that means this patient is either having HIV or the patient is having some connective tissue disorder, and the most common is sarcoidosis. So these are the two conditions where you have GB syndrome with CSF pleocytosis. Okay. What day of the GB syndrome you are expecting this to show in the CSF? What day of
After
GB syndrome?
second week.
Second week, huh? After
After a
second
week.
week. Okay, end of the first week. So end of the first week. So 7th day onwards, you will be able to make out that. Before that, it will not be there. Okay. What is the finding you get in case of subarachnoid hemorrhage?
Xanthochromia.
So what is xanthochromia?
Due to degenerated red blood cells, the color appears yellow.
Why is the color yellow?
Due to
What makes the color yellow?
hematin, because of hematin.
Hematin? Not hematin.
Degenerated hemoglobin producing belly. Yeah.
Okay, so the bilirubin pigments of that. Okay, you might get yellow color CSF, especially in children when there is connectors, or when you have severe jaundice. Also, you can get CSF which is yellow colored. Okay, how do you differentiate a traumatic tap versus subarachnoid hemorrhage?
In traumatic taps, sir, once the blood will come, after that the CSF will be there.
Okay, so In the initial 1 or 2 bottles or a few drops will be bloody. After that, it will clear in case of traumatic, whereas in subarachnoid hemorrhage, it will be uniformly colored. Yes. Other difference? When you look under microscopy, what will you find in traumatic? What will you find in subarachnoid?
Morphology of RBC.
Yes, in traumatic, you will have fresh RBCs. Whereas in case of subarachnoid, the RBCs would have already been lysed, isn't it? So it will be older, the lysed RBCs, that is what you're seeing. And as you said, xanthochromia is a feature which you will see in case of when you centrifuge it, the supernatant will become color there, which is seen only in subarachnoid hemorrhage. It will not be seen in traumatic trap. Traumatic trap supernatant will still be red. It will not be yellow. Okay. Okay. What is Queckenstedt test?
Pressure applied on
Yes.
In
IJV,
bilateral internal jugular veins.
jugular vein.
What
To
will
know
happen?
the patency.
Increase in CSF pressure after applying pressure in the internal
Pressure on
jugular
the
vein.
jugular.
If
So when you connect it to the pressure, that is when you're connecting to the measuring tube that you're measuring, if you apply pressure on the jugular, the column should move up. If it is not moving up, that indicates
High spinal block.
okay, it could be a spinal block or it could be sinuses. Your all your whatever sinuses block. So it could be in the sinuses, your sagittal sinus or all those sinuses which are connected to the jugular. If you have a block in that also, you could get this. Okay. What is Freund syndrome? What is Freund syndrome?
Complete subarachnoid block, CSF finding.
Due to what? Due to what? Anyone?
Tumors or
okay, so if there is a spinal block due to a tumor there, what happens? The tumor would shed the cells. So when you do a CSF analysis, you will find something like a xanthochromia, but it is not due to the subarachnoid hemorrhage. It is because of a spinal block due to a tumor. And when we do a cytology, you will find that there are tumor cells rather than crenulated RBCs that you see. So it's one of the differential diagnoses for xanthochromia. Okay. So what are the specific investigations that you'll do in a CSF to diagnose multiple sclerosis?
Oligoclonal bank.
Okay, oligoclonal blanks that you will be doing. For NMO?
Aquaporin 4 antibodies.
Okay, you can do aquaporin 4 antibodies. Okay. For tuberculosis? Tuberculosis?
TB-NAT.
Okay, you can do the anti-adenosine deaminase. You can do the gene expert. You can culture it also. Okay, in a HIV patient, any other specific test you do from the CSF?
India ink preparation.
Okay, you can do the India ink preparation to rule out cryptococcus. Then any other specific for cryptococcal, you'll do the cryptococcal antigen.
Viral PCR.
You can do the cryptococcal, you don't do. Cryptococcus is not a virus. Cryptococcal antigen, that's the most specific test that you do. Then you can do the PCR for other things. You could do it for toxo, you could do it for JC virus. So CSF in a patient who has HIV, lot of infections could be there, so you'll have to do that. So these are the common questions that are asked when the lumbar puncture needle is kept. What are the complications of lumbar puncture?
post-puncture headache, hypotension.
Post-puncture headache, correct. Then other complications?
Herniation.
Infection.
Okay, if you are not careful, then you could cause herniation. Yes. Infections, you could introduce infections there, correct. So these are the common complications that you could get during the spinal procedure. Post procedure, you could get this. Okay, so the next set of things that are kept are your bone marrow needles. So you have the bone marrow aspiration needle and the bone marrow biopsy needle. The bone marrow aspiration needle, you know, it's the CLIMA, and the biopsy needle. This is the metallic one. What we use off late is the This is the bone marrow aspiration needle, and the one which we use for biopsy is this is what is used now. So it's a disposable needle that is there. Okay. So what are the indications for bone marrow aspiration? Yes.
Pancytopenia.
Okay, pancytopenias. Okay.
PUO.
Pyrexia of unknown origin. Yes. More blood indications.
Multiple myeloma.
Okay. When
ITP.
you're suspecting any anemia of unknown etiology, leukopenia or leukocytosis, thrombocytopenia or thrombocytosis, anemia or polycythemia, pancytopenia, leukemias, lymphomas, myeloma, then pyrexia of unknown origin. And sometimes whenever you have you're suspecting a diffuse granulomatous diseases, okay, or sometimes for your kala azar you may have to do it. So certain PUOs only, or if they have organomegaly and some childhood diseases like glycogen storage diseases, etc., the marrow may be indicated. Lymphoma staging, yes, lymphoma staging also marrow is indicated. Bilateral you do to look for the, and yes, for harvesting the bone marrow is okay, fine. So these are the indications that are there. When do you do the bone marrow biopsy? When do you do aspiration? When do you do bone marrow? Okay, dry tap. So what are the conditions where you can get that?
Myelofibrosis.
Myelofibrosis,
Lymphomas.
correct. And, okay, whenever the marrow is packed either with cells or fibrosis. So whenever the marrow is packed with cells, okay, very severe leukemias where the marrow is completely packed because of cells, you could get a dry tap, but myelofibrosis can be also indicated. So there where you can get the, that's where you do the bone marrow biopsy. Okay, what are the sites of bone marrow aspiration? Sites of bone marrow aspiration?
Posterior iliac crest, anterior.
Okay, in the iliac crest, the
Manubrium
posterior
sternum.
manubrium sternum, yes. Then
Anterior tibia.
okay, anterior tibia, the tibial, this one, you could do it in children. Okay, in adults, you do it in the sternum or in the iliac crest, but biopsy is always done in the iliac crest. Biopsy is always done in the iliac crest. Okay. What are the contraindications for bone marrow?
Periostitis.
Okay.
Bleeding diathysis.
Hemophilia.
Okay.
Platelet count
Local-
less than 1 lakh.
Platelet
Local
count is a very,
infection.
very rare. Again, remember, bone marrow is not like a CSF. CSF is where you're going into a blind space there. Bone marrow, the bleeding will occur within the marrow space, and the marrow space itself, it will get clotted. So the bleeding chances, any condition like bleeding, like you said, severe thrombocytopenia is not a contraindication. Coagulopathy, unless it is very severe and the patient has spontaneous bleeding, that can be. But remember, platelet is not a contraint. Platelet is a severe thrombocytopenia, maybe a platelet count less than 20, etc. is contraindication for lumbar puncture, or less than 50,000, not 20. Less than 50,000 is a contraindication for lumbar puncture. But for bone marrow aspiration, please remember you can do it with the platelet count of 1 lakh. Sorry, 1,000. 1,000 also you can do platelet count. But yes, clotting, you have to be a little careful. But again, since that is a closed space, wherever you're doing the aspiration, it's a closed space. It will form a clot there. So it will it will block itself there. So please remember, even in ITP, when the platelet count is 1,000, we can still do a bone marrow aspiration. Okay. So the absolute contraindication is maybe a severe coagulopathy, or a local, that part is infected, but you have a large site, you can do anywhere in the iliac crest. So if one side is infected, you can do it on the other side. The most important consent for every procedure is a non-consent. That is always, you should remember, a non-consent or a patient not giving a consent is an absolute contraindication. Otherwise, there is no, please remember, for bone marrow, low platelets is not a contraindication. Okay. And again, in bone marrow, whenever they ask you, they will ask you the findings in various diseases. What do you get in the various types of anemias? What do you get in myeloma? What do you get in leukemias? And how do you differentiate a myeloblast versus lymphoblast? And what do you get in megaloblastic anemia? And all those things you have to know. And at presently, when you do the bone marrow, especially in leukemias and lymphomas. We also send for immunohistochemistry. The flow cytometry is also done for typing of the cells. So that is the bone marrow. What are the complications of bone marrow procedure?
Infection at the site.
Okay, you can introduce infection, but again, you have to be careful there. So that's not that infection should not occur.
Hemorrhage.
Okay, hemorrhage again. The lethal complications can generally happen if you're doing a sternal puncture, especially in elderly who have a osteoporotic bone. You can end up going through and through, and the patient can develop a hemopericardium and die. So there have been reports and of patients dying due to a sternal puncture because of hemopericardium. So nothing can be done there. But in the iliac crest is absolutely safe. Iliac crest is absolutely fine. There is no major. It's a big crest there, and you can see the. I mean, you can actually feel the bone, and so it's very unlikely that you will hit certain structures other than the bone and cause problem. But yes, you can cause some nerve or some muscles can get there, but they are all very minor. Pain can be there, and as you said, periostitis can be there because of your infection. Otherwise, there is no major complication with the iliac, but with the sternum, you have a lethal complication of sternal. You can go through and directly enter the pericardium or the aorta there, and then the patient can die on spot. So that complication is there. So that's about the bone marrow aspiration and the biopsy. Again, a very common thing that is asked. Any doubts with that? Fine. So that's the biopsy needle which we use. Yes. What's this?
Wim Silverman.
Wim Silverman liver biopsy.
Okay. Again, this is an outdated instrument which is no longer used. We don't use this for liver biopsy. Now, for all the organ biopsies, what do we use? For all the liver or the kidney biopsy, what do we use now?
True cut biopsy.
Yeah, we use true cut. We use the biopsy guns. You would have seen the kidney biopsy guns. The same guns can be used for all the organs that are there. We don't use this, but this still sometimes in the instrument set is kept. This is the Wim Silverman biphalanged. It has a stillet which is biphalanged. Okay. So what are the indications for a liver biopsy?
Storage disorders.
That's
Liver mass.
Common ones.
Cirrhosis.
Okay, cirrhosis of liver.
Liver mass.
Liver mass, if you're suspecting a hepatocellular carcinoma, correct. Then
Hemochromatosis and Wilson.
okay. Again, that is one type of a cirrhosis sort of thing only, as you said. A hepatomegaly, if you do not have a cause there and a hepatomegaly. Staging of the hepatitis, okay. The chronic hepatitis staging systems are there, which you can autoimmune hepatitis, your specific findings that are there. Again, liver biopsy is not a common investigation that we do unless we are not able to find out a diagnosis. Kidney biopsy we do very often, but liver biopsy we do not so often do because you have other tests to corroborate and find out. Okay, so whenever there is PUO, sometimes we have to require that. The contraindications for liver biopsy.
Hydrated cyst.
Okay. The most important is coagulopathy. Okay. Coagulopathy is absolute contraindications. Hydrated cyst, yes, you should not touch it because it can precipitate anaphylaxis. The other very important thing that since the liver is, before you touch the liver, you're supposed to do an ultrasound. And you have to rule out, you have to rule out vascular lesions, correct? Anything else you want to rule out? You should make sure that the biliary radicals are not dilated. So there should not be any intrahepatic biliary dilatation, because if you touch the biliary radicals, you can cause what complication? Yeah, you can cause biliary peritonitis, and that is lethal. Okay, biliary peritonitis is one almost sure shot death. You do not have anything to be done for that. So you have to be careful of these things. Otherwise, you can do the liver biopsy. And so presently, this instrument is not used. What we use for the liver biopsy at present is the true cut. Okay, true cut needle. This is This is the classical true cut that we use, the Manganese technique that is used, and this is the biopsy gun, okay, which can be used for any biopsy. Most oftenly we use for kidney biopsy. We can use it the same thing for the liver also. And almost all the new procedures that we do at present are always guided, because you would want to go and hit the particular lesion if it is there. Okay, so what are the common indications of kidney biopsy? Yes.
Nephrotic syndrome.
Okay, when you want to diagnose or type of nephrotic syndrome, correct? Then
lupus nephritis.
Yeah, nephrotic, whatever, nephrotic or whatever clinic, same, whichever cause of glomerulonephritis. Then
amyloidosis.
Okay, amyloidosis. Okay, fine. Then
graft rejection.
Yes, graft rejection. That's a very important post-transplant. When you're supposed to diagnose, when you have to diagnose that it's what is there. Yes. Then what are the other causes? Kidney biopsy. Hematuриas or proteinuриas, which are without any cause. You're not able to find out a cause based on your blood investigations. Maybe that's what. Rapidly progressive glomerulonephritis, RPGNs. Okay, RPGNs, that would be there. Okay. What are the contraindications for renal biopsy?
Single functioning kidney disease.
Single functioning kidney should not be touched, correct? Then
small
shrunken kidneys. Okay, shrunken kidneys, because already it is gone. Okay, if there is an active infection, yes, that could be a this one.
Coagulation disorders.
Coagulation, severe coagulation and thrombocytopenia are little contraindications.
CKD5.
Okay, CKD5, yes, there is no indication. That's what, already contracted kidneys, isn't it? Shrunken kidneys. Again, rapidly progressive. If the renal functions is worsening very, very rapidly, by doing a kidney biopsy, you might worsen it further. So that's also a relative contraindication. Okay, again, a few features of kidney biopsy you'll have to know. And okay, what is this?
Gastric lavage tube.
Okay, so this is the gastric lavage tube. So you get two types of them. One is the Evalds and one is the Boas. So again, what are the contraindications for this procedure? Gastric lavage is done for poisoning. So what are the contraindications?
Corrosive.
Petrol or kerosene injection.
Corrosive poisoning, correct. More common, corrosive, you may not get it. Yes, kerosene. Why do you don't do it in kerosene?
Aspiration pneumonia.
Okay, so kerosene is the high chance of aspiration, and it can cause chemical pneumonitis. Because of that, you have to not do it. Okay, any other contraindications?
Patient in convulsions.
Okay, that is okay. That's one relative. I think in forensic and all they teach that as convulsions, but that's not a medical contraindication.
Comatose patient.
Again, that's also in forensic they teach you that, but comatose patients, what is the problem in putting it? There is no problem at all. Okay, maybe you have to be careful. That's all. Okay, so corrosives are the most. And if you had a person who has already had an upper GI bleed, if he had an alcoholic patient who had a variceal hemorrhage, such patients you would want to not touch. You would not put this at all. Okay, and whenever gastric lavage tube is kept, they will ask you about the various antidotes and for which poisons which we are using, which antidote, and some common poisons. I think we discussed some of the poisons in the last OP poisoning and the management. They'll ask you what are the other common insecticides and the management protocols, and what are the antidotes. That's very, very commonly that is asked. Okay.
Endotracheal tube.
Endotracheal tube, yes. What type of endotracheal tube?
Cuffed.
Cuffed polythene.
Cuffed endotracheal tube. Why is the cuff there?
Self-retaining.
Self-retaining.
To prevent aspiration.
Prevent aspiration.
Prevent aspiration. That's why the cuff is okay. To maintain the position. Okay. Fine. So what is the cuff inflated with?
Air.
Air. Please
Air.
remember this very often. I don't know how you would have done it so many times, but still, sometimes in the exam you end up telling saline and then there is no go. After that, it's the end of the story. So it is air that is used to inflate it, and you will have to, yes, the indications, the common indications. When do you do this?
Respiratory failure.
Okay, so when you're planning a mechanical ventilation, when a patient is in comatose states, you want to do that. Other indications? For ventilation is one.
General anesthesia.
Okay, general anesthesia, correct. Then when a patient is having he's unconscious and airway protection. Okay, so airway protection for mechanical ventilation, for respiratory failure. So these are the main things that we do this intubation for. How long can we keep this tube?
7 days.
10 days.
7 days, 7 to 10 days is the maximum. After that, you will have to change over to a tracheostomy that is there. Okay, what are the complications? Complications.
Stenosis, tracheal stenosis.
If it is present for a long time, then you could stenosis. Common ones. What will happen if it is? Okay, it could get more than kinking. It would cause block, isn't it? Secretions can get clogged there. You can cause yes, the patient is connected to ventilator, so there could be hospital acquired pneumonias that could occur due to this. And long standing, yes, as you said, there could be stenosis, there could be tracheal tracheomalacia. Yes, correct, what you written, tracheomalacia, and bleeding, etc. can happen. Pneumothorax, yes, if you are inverted ventrally, very, yeah, if it is, you can produce mediastinum or a subcutaneous emphysema. Pneumothorax is a little too much unless you have been very you have pushed it really too much. Okay, so that's about the endotracheal tube. What is it made up of?
PVC.
Okay, what is this?
Ambu bag with.
Okay, ambu
mask.
bag and mask.
Bag and
mask ventilation.
What is the full form of ambu?
Artificial manual breathing unit.
Okay, artificial
Ambulatory.
manual breathing unit. Please remember this. This is very commonly asked, and I don't know for what reason. More than 60% to say many other full forms of that. Okay, so this is used for. What is this used for? Yes, oxygenation when you start the ACLS or your basic ABC. When you do that, that's when you do that pre-oxygenation, etc. Before you intubate, you do that. Yes, so that's the ambu mask that we use. Yes.
Laryngoscope.
This is laryngoscope, so you know how it is to be used, and generally, which hand will you hold this laryngoscope in?
Left.
Non-dominant. Non-dominant hand. Okay, non-dominant hand you're holding. And again, I think if your vivas are going, they will obviously ask you to demonstrate. And some of the OSCE stations have your what you say, the mannequins are there, so they do ask you to demonstrate sometimes. How do you intubate and how do you do that? So this is a common instrument that is kept. They'll dismantle and ask you to reassemble it. Okay, what is this? Okay, so that's the, yes, I think in the chat here written pleural biopsy needle. So this is the pleural biopsy needle, goes by the name of
Abraham.
Yeah, Copes, Abraham Copes, COPES, Copes needle that is. So what are the indications for pleural biopsy? So how do you make out is because it has that, you can see that at one edge, you can see this part here.
Massive effusion.
Okay, so this is where you're seeing it's like a hook there, isn't it? So that's the hook. That's how you differentiate it from other needles. Yes. It has a trocar, it has a cannula, and it has a hook at the edge. Indications, pleural biopsy.
Pleural tuberculosis.
Okay, sometimes when you have pleural effusion without a cause, or you have evaluated everything and you're still not able to find out, or the patient is already on ICD, before you want to remove the ICD, you can do one pleural biopsy and make out. You have found certain pleural nodules on a CT scan, okay, and then you want to do that, or such thing like that. So such are the indications for doing a pleural mesothelioma or a tumor there sitting. So those are the indications that we do. Again, biopsy of pleura for nodules, etc., can be done through CT guided FNA also. We don't have to use this. So again, the indications are very, very minimal for pleural biopsy now.
Foley's catheter.
Self-retaining
Foley's,
catheter.
what type of catheter?
Self-retaining.
It's a self-retaining catheter. So it's a self-retaining catheter. So how do you inflate the bulb?
With distilled water.
Distilled water.
Of distilled water.
Okay, so this is distilled water. Why not saline?
It causes crystals and there will be electrode rupture.
Okay, so saline will crystallize and then you can't deflate it. Okay, so you cannot deflate it after when you want to remove. So crystallization of saline can occur. Why not air?
It will float.
Okay, so if you, yes, so if you put air into it and this is inside the bladder, so this will float on top of the urine, and the eyes which are there, you can see these eyes which are there on side will be above the level of urine, so it won't drain. Okay, so that's the Foley's catheter that we're using. So indications of Foley's catheterization.
Retention
Trauma
of urine
patient.
should be avoided.
Okay, so whenever there is an acute retention of urine, correct? Then
Trauma patient.
Interp injury.
Trauma? Why? Which trauma? Which trauma you're saying?
Trauma patient, basically immobilization needed whenever, like in surgery.
Okay, such patients they can put on condom catheter also. We don't require to put an indwelling catheter.
Neurogenic bladder.
A neurogenic bladder. Okay. Spinal cord disease, LMN bladders. Yes, paraplegic patients. Correct.
Prostate surgery.
Whenever there is a procedural, that is when you do it. What are the absolute contraindication for catheterization?
Trauma, urethral trauma.
Urethral. If you find that there is a meatal bleed, so that's where you're not supposed to do it. Okay. So post procedure also. Okay. Again, prostatic surgeries, you use this for catheter irrigation. Whenever there is somebody who had a hematuria and a hematoma in the bladder, then we use this for irrigation. We use one more use. This is a only 2 lumen. No? You have one more lumen that is there for which you will use. Yeah, for which has to be 3-way. That is used only for irrigation. So what do we irrigate it with now?
Normal water or
normal water, no. Bladder irrigation is done with what?
Distilled water.
Saline?
Saline with betadine.
Saline with betadine. Why? Why betadine? What will happen if you put so much of saline? Irrigation has to be done liters together. 20 to 30 liters of fluid will go inside. What will happen?
Dilutional hyponatremia.
It will cause dilutional hyponatremia. If you put water, what will happen? Distilled water. What will happen?
Increase in oncotic pressure.
Yeah?
Increase in oncotic pressure, hydrostatic pressure will be increased.
So what will it produce if so much of water is
edema,
pushed in?
edema.
Edema won't happen. Edema won't happen like that. So hypoosmolar state, no? So it won't penetrate like that. Okay, again, it can cause some sort of a dilutional state. So what is used at present for bladder irrigation? In the urology wards you would have seen those huge packets which would be hung by the patient's side. Anybody? Saline was used. Saline is still used. I'm not saying saline is not used, but there are huge. Yes? I can't hear you. Nobody. It's not boric acid. Glycine, which is used for irrigation. Okay. Glycine is used for irrigation. Okay. What are the complications of catheterization?
The urethral rupture.
Okay, you can cause urethral injuries. Yes. Most common, what's the complication? Infection is the most common complication. Sending infection. and that can cause recurrent UTI, chronic UTIs, that is there. So that's the most important complication that could be seen. And yes, as you said, urethral injury can occur, trauma, hematuria can happen due to that. Yes, then okay. If
Paraphimosis.
paraphimosis, so that is yeah, the doctors, if you do not do it
Negligence
properly,
of retract back
if you
pain
do
after
not
septal
retract the prepuce properly back, so you can cause paraphimosis. Again, a very, very common complication which is often done if inadvertently it is caused. Okay. How often have to change this?
If it is rubber
2
catheter,
weeks.
within 1 week. If it is silicone, by 1 month we can keep.
Okay, so this ideally by 7 to 10 days, not more than that. Silicone can be kept for a 3 to 4 weeks. Silicone can be kept for 3 to 4 weeks. That's it. Okay. If you're not able to remove the catheter, what do you do? If the
ultrasound guided puncture of the bulb.
So ultrasound guided puncture. So that is how you're supposed to remove it, because that bulb is not deflating. The bulb does not get deflated. You'll have to do that. Any other way? Earlier ways they used to do?
Inflate it more so that it ruptures.
Okay, but then sometimes it does not get inflated because that full pathway is blocked. Puncture the valve near the bifurcation. Okay, sometimes you can puncture it a little higher and see. Okay, you can see it. But earlier what they used to do is, yeah, as you said, now what we do is ultrasound guided puncture of that so that it deflates. Earlier they used to instill something into that so that it would burst out. Anything specific they used to instill? You should fill the bladder fully and then make sure that this bulb is inside, the inflated bulb is inside that, fill the bladder with saline, and then you make sure that this is inside, and then you instill. Nobody. What was getting instilled? Now we don't use it anymore, so that it would totally burst open inside the bladder. No one? What was used? Still it is practiced. What acid? Not acid. I mean, it's acidic substance only, but not actual acid as an acid. No, silver nitrate is too acidic. It is used in ENT wards. You would have seen it very commonly. No one? Ether. Yes. Used to instill ether. Okay. Ether into that, and then that would burst it open. So, but again, now we don't use that. We have to make sure that it is punctured. Ultrasound guided puncture is what we do now. Okay. Fine.
Insulin syringe.
So this is a 1 cc syringe which is used for insulin because you have the units. So again, a very common question they ask you. What are the types you have? There are 2 types of insulin syringes. What are the 2 types?
100 units, 40 units.
100 units and 40 units. So it's very important because 1 cc is 100 units and 1 cc is 40 units. Insulin also comes in that preparation. So you will have to use the 40 unit syringe for 40 units vial and 100 units for the 100 units vial. So it's very important. And again, a very, very common question they ask you. How do you give the insulin? What's the route of administration? Subcutaneous. So you should know that subcutaneous, how do you give it? You have to raise and then you have to put it right, stop, and then push it and then release the skin. So that's very important. So what are the common side effects, or what are the problems associated with insulin?
Hypoglycemia.
Okay, hypoglycemia is the commonest, followed by
lipodystrophy.
Okay, lipodystrophy can occur. You can have weight gain also. Edema can also be there. weight gain and edema, the other complications that could occur with insulin therapy. So, what is this?
Tuberculin syringe.
Okay, so this is the tuberculin syringe that we're using. So again, this is also 1 cc syringe. How do you differentiate it, whether it is a tuberculin syringe or the insulin syringes? By looking at the markings. Okay, so and usually the tuberculin syringes, it has a brown colored hub here, whereas in the insulin syringe is the red color hub there. Okay, so again, tuberculin, very common question they ask you. What is tuberculin and what do you use this for? What do we use this for?
MAN2.
Okay, it's used for MAN2. Yes, tuberculin skin test, MAN2 test. You have to know thoroughly about the MAN2 test. So how do you do the MAN2 test, and what are the, how do you interpret the MAN2 test? Yes. How much of tuberculin we are going to use? In this syringe, how much of tuberculin we are going to use for MAN2? So it's 0.1 ml.
ml.
Yeah, 0.1 ml. That's still here only we are going to take. And then again, there is something called as a boosted MAN2 where you're using the double strength if you are doubtful. But normally we use 0.1 ml only. And we are going to give intradermally in the forearm. Okay, intradermal in the forearm. That is what we are using there. And how do you know it is intradermal?
Bleb is formed.
Okay, you should be able to make sure that there is a nice bleb or a wheal is formed there. And you have to look for induration after ideally 72 hours, but you can see it early at 48 hours also. So ideally it is read at 72 hours. So when do you say it's positive? When do you say MAN2 is positive? Yes. How much should be the induration? Yes, more than 10 millimeters is positive in duration. When do you consider 5 millimeters positive in duration?
Immunocompromised patients like HIV.
Immunocompromised, especially HIV, or if the patient is direct contact of a sputum positive, a positive patient, sputum positive, that is where we take the measurement. You can take the maximum measurement. It's not necessary that you have to take it transverse, but that's how you're supposed to give a wheal. The maximum should be in the transverse position. That's why. So you can take 5 millimeters in an immunocompromised patient or patient who is on drugs which are immunosuppressive. In such patients, you can do it. Yes, in India, 15 millimeters positive. That's the question, because the hyperendemic, almost all of us, especially the medical professionals and others, will be positive. Again, please remember, tuberculin test is considered not as a test for diagnosis. It is not a diagnostic test for a infection. It's a diagnostic, it's a test for, it's not for the disease. Sorry, it is not for the disease, it is for the infection. You can diagnose it in the presence of other clinical features. If you have lymph nodes which are there, or if the patient has a tuberculous effusion when you have nothing else coming positive, then maybe possibly you can take it as a this one. You can take it as for that. And yes, it is used for screening. And many of the patients who are positive with this might require tuberculin INH prophylaxis or sometimes the full treatment, especially in places where the tuberculosis is not so rampant, maybe in the West, that is there. So those are the instruments that are kept, that is there, which are commonly asked for you. The next set of questions, I think one of the common images that are kept are the various flow volume loops that are there in the PFT. So you have to know the pattern of the flow volume loop and what is the individual disease that you're getting and what is the pattern that you see. So the first one, all of you know, is normal. So you know that there is a inspiration. This is how the this is how the inspiration would start from, and you get this parabola sort of thing. And then the expiration would start, and you see predominantly the expiration, majority of the expiration has happened within the first few. And after that, there is a drop that could happen. So that's the first one that you're seeing there. So what is the second one showing? You can see that?
Obstructive.
Okay, second one is the classical obstructive pattern that you can see there. There is a scooping of the expiration that is happening. You can see nicely scoop down. It never reaches, and it is very slow that happens. Very, very slow that is happening, that is there. So that is the characteristic pattern of an obstructive airway disease. Okay. The next one.
Restrictive.
Yes. So the next one, what you're seeing is the restrictive pattern.
Restrictive lung disease.
Where both inspiratory as well as the expiratory is very, very small that you're seeing here. Very, very characteristic. So you have it is very, very small. It does not reach the total lung capacity itself. So that's the classical restrictive pattern that you have. The next pattern is where you have certain obstructions, which could be either variable extrathoracic obstruction, where you have just a problem which you're seeing very characteristically. You see it during the inspiration, that you can see that it is going much slower there. Whereas in fixed upper airway obstruction, where you could get this classical pattern, where you have a rectangular pattern that you could get. Neuromuscular weakness is something like the restrictive pattern that you're seeing. Neuromuscular weakness is something like the restrictive, but will be much more rounded in shape. Okay, much more rounded and much smaller compared to the classical restrictive disease that you can see. So the most common questions that they ask you is the pattern that you get is in obstructive disease, where you have the scooping that you can see there. And then they'll ask you about the various other values that you can get, and what are the ratios that you can see, and how do you differentiate an obstructive versus a bronchial asthma versus a COPD. How do you differentiate that? A bronchial asthma versus COPD? Yes. Bronchoreversibility, isn't it? So what is reversibility? What is the definition of reversibility? After giving bronchodilator, you should have a 12% improvement. So if you have a 12% improvement, that means it's a bronchial asthma. Whereas in COPD, you will have a reversibility, but it will not be a 12% reversibility that will be seen. So this is a common question. Then they ask you about peak expiratory flow rate. That's what we use. You have the peak flow meters. That is for the day-to-day monitoring of bronchial asthma or COPD patients, how much of peak expiratory flow. That's based on that you can adjust the drugs, bronchodilators, based on that. Okay. So I think finally, I think we've already finished an hour. Okay, quickly, let me just discuss certain concepts of ABGs. You have simple ABGs only that are kept. So basically, in ABGs, when you see, you should know the normal values, and you should know how do you interpret it as. So you know the normal values, the pH 7.36 to 7.44. The bicarbonate is around 24 that you see. PCO2, remember, it is 40, 45 is the upper limit that is there. The H plus, which we don't normally calculate, 36 to 44, we don't see it. Important thing that you have to remember is, what is severe acidosis? What is severe alkalosis? Severe acidosis when the pH is less than 7.2, and severe alkalosis when it's more than 7.6. Okay, so these are the severe ones. That means the compensatory mechanisms are not acting or have failed to act. That's when the severity would come. A patient with severe acidosis would require hemodialysis or something, and alkalosis possibly would require ventilation. So these are the important basic terminologies that you have to remember. Always estimating the H plus from the pH. This is a simple thing that you know. That is how you calculate the H plus based on the pH. So you know that 7.4 would correspond to around 40. That's a normal H plus. And with every 1.1 drop in the H plus, the pH, the one drop in the H plus, one drop in the pH, the H plus would add up by 1.25. So from 40 it becomes 50, and then it becomes 62, 80, and 100. So a 7 pH would correspond to around 100 H plus, 100 H plus, okay, 100 H plus. Whereas if you have a pH which would come to, if you're seeing on the alkalotic side, when you're seeing the alkalosis, a 7.6, this is what I told you is severe, would correspond to a H plus around 25. So it's a multiplication of 1.25 on this side and a multiplication of 0.8 on this side. Again, very common questions asked, because based on this you would say whether there is actually a proper ABG or not. So very important. That's what, even a 0.1 change, 0.01 change in the pH, your H plus concentration would grossly different. So that is what you have to remember that. So if you see that the pH from 7.40, this one is around 40. When it comes to 7.39, it becomes 41. Then it immediately drops to like that. So even one change can cause the difference. Very importantly, you should always check for the electrolytes, especially whenever there is an acidosis. Whenever there is an acidosis that is there, you have to check for the electrolytes. That is important because potassium is goes hand in hand there, and also sodium, that has to be looked for that. That is what you have to remember. This is what is important that you have to understand. So always check it like that. Check for validity, I won't go to this. Okay, we'll simply go on to that. Now, first of all, look for whether it is an acidosis or an alkalosis by looking at the pH. So you should see whether the pH is lower. If the pH is lower, then we know it is acidosis. Once you see the pH is lower, look at bicarbonate and look at PCO2. So if the bicarbonate is lower and the pH is lower, then we know it's a metabolic complication. If the PCO2 is higher and there is a pH lower, then it is respiratory. So you'll have to basically look for it and look for the combination that could occur. So whenever the pH is lower and the bicarbonate lower, that's the most common thing that of all we encounter. Though I think presently with the COVID and so much of COVID pneumonias, you could see the respiratory problems also. But before COVID, possibly what the most common electrolyte abnormality or acid-base metabolism change that we would encounter is a metabolic acidosis. Always remember the secondary change. So when you have the, that would be the next one. So if supposedly the bicarbonate is coming low, the secondary change would be the PCO2 would come down, and that would net effect would be neutralized. Always remember, if the pH is normal, if the pH is near normal, that is there, that means compensation has occurred. So compensation has already occurred. So if the pH is between 7.35 to 7.4, so it's on the lower side of that, that means there is an acidosis which has got compensated. So acidosis has been compensated by the other mechanism. And if the pH is between 7.4 to 7.45, that means alkalosis has got compensated, or there is a mixed acid-base disorder. So that means there is a respiratory acidosis and a metabolic alkalosis going together, or a metabolic acidosis with a respiratory alkalosis. So if the pH is normal, if it is on the lower side, that means that is acidosis which is compensated. If it is on the higher side, that is 7.4 to 7.5, always remember that the alkalosis has got compensated. So that's how you have to go into list and check it. Check for the compensation. Simple thing that you have to remember, that if it is an acute condition that you're looking at, most of the ABGs that you're going to see in the exams or whatever are acute complications that you're acute things that you're going to see. So remember, metabolic acidosis, whenever it is there, the PCO2 should decrease by 1.2 millimeters if the PCO2 should decrease per bicarbonate that we are seeing. So that's a simple thing that you're going to see. That is the compensation. The maximum it can reach is 15 that you can see. If it is metabolic alkalosis, it should increase by 0.6 millimeters per milliequivalent rise. So that would be for the metabolic. So metabolic only we see about the acidosis and alkalosis. When you say the respiratory, it could be an acute or chronic. The most common example that is kept for you is an acute respiratory acidosis that could be seen, where the bicarbonate would increase by 1 milliequivalents per liter per each 10 millimeters of PCO2. So PCO2 going from 40 to 45 to 55, you would have a rise of bicarbonate by 1. That would be the commonest metabolism that you could see that. Okay, I won't go on to, again, remember the compensation takes time to occur. It won't happen rapidly there. So it would take time there. Compensations would not occur so fast. After that, once you have noticed that there is an acidosis, always calculate the anion gap. Again, a very, very common question that is asked for you is about anion gap. And how do you calculate the anion gap? All of you know it is the sodium minus chloride and bicarbonate. You can add sodium plus potassium. And the normal anion gap is, how much is the normal anion gap?
12.
Okay,
8
so
to
12
12.
to, yeah, 12, you could say upper limit can be kept as 14 there. So that's the normal anion gap that's there. So basically the anion gap is due to the unmeasured anions, unmeasured cations that you have. So this is not measured routinely, and that is what causes it. Especially the acidosis part of it is because of this acetoacetate, beta hydroxybutyrate, the lactate, etc. So whenever you have a high anion gap acidosis, please remember, very, very commonly asked, you will be asked this question: what are the high anion gap acidosis that you have? The most common being lactic acidosis, could be due to sepsis, could be due to drugs, could be due to starvation. It could be ketoacidosis, which could be secondary to diabetes, alcoholic, and starvation, ketoacidosis. Any other condition can produce ketoacidosis other than these three? Other than these three conditions, anywhere else you can get ketoacidosis? Okay, please remember pregnancy, hyperemesis. This is a very important thing. Some sort of a starvation that happens there. So pregnancy, it has to be treated with thiamine there. Okay. Renal failure, again, please remember renal failure can be example for both high anion or normal anion. And then the drugs, ethylene glycol, methanol, salicylates, and propylene glycol. So you have an acronym for this. The acronym goes by the name of mud piles, correct? Yes. So mud piles is the acronym for this. Again, remember this is asked for you and you will have to look for it. So various mnemonics are there. Mud piles is one, the gold mark is other one. The normal anion gap acidosis, always remember, normal anion gap acidosis, most commonly that we encounter is the renal tubular acidosis. Okay, I won't go on to the correction of the anion gap. Okay, and once the anion gap, the next thing that you look for is urine, but then this will not be given for in the exam. The urine values are not given, so you don't require to look for that. I'll quickly go on to certain examples. Okay, delta gap is where you have a mixed disorders, a concurrent metabolic disorders. That is where you require to calculate the delta gap. That is by the delta gap is, or the delta ratio is between the anion gap and the bicarbonate levels. You want to know whether there is a mixture of the anion gaps that is there. That is, if the delta gap or the ratio is less than 1, that means there is a combination of high anion plus a normal anion gap. If it is 1 to 2, then it's a pure high anion gap metabolic acidosis. And if it is more than 2, that means there is a coexisting metabolic alkalosis. Okay, so let's go on to analysis of some ABGs, 1 or 2 ABGs that I'll discuss with you. Okay, so here we have a 40-year-old man who has come with diarrhea and he is breathless for 2 days, and this is the ABG that is given to you. Anyone can quickly tell me what is the abnormality that you're seeing here? Somebody can unmute and tell.
Metabolic acidosis.
Okay, so there is a metabolic acidosis that is there, 7.23 pH, 7.28 that is the pH. So it's a metabolic acidosis. You can see that the bicarb is low and the pH is also low. Is it compensated or it is not compensated? It is not compensated. What is the compensation that you would expect in this patient?
No, it is compensated.
Respiratory.
You would want to get a respiratory alkalosis that you would want to see. The PCO2 should have, what should have happened to the PCO2?
Fallen.
It should have fallen. So normal PCO2, we know that it is around 40. It has come down to 29. So you were saying that there is already a compensation that is there, but it is not fully compensated because the pH is still low that is there. Okay. Electrolyte, sodium is normal, potassium is low. So what would be a final diagnosis? There is a mild renal failure that's there. So metabolic acidosis could be secondary to.
Excuse me, sir. Hello, sir.
Yes.
Sir, for that compensation, if you have to look the PCO2, expected PCO2 or a PS. In
I
case of
can't hear
metabolic
you.
in case of metabolic acidosis, the compensation will be PCO2 false.
Correct.
We should look PCO2 level, whether it's fall according to the expected PCO2 level, or we should look the pH level, sir. pH level should be according to 7.4.
No, based on the pH only, you'll be able to make out whether it is compensated or not. Na?
So for this case, pH, sir?
This pH is not compensated. It is not fully compensated. So either there is a compensation is it is not happened fully, isn't it? So for this PCO2,
on the PCO2 level, based on the PCO2, we should not comment, sir. For that patient, previous slide, for that patient, the expected PCO2 would be 15 plus 12, like 15 plus plus bicarbonate, it is around 27.
Okay.
For correction, we can order plus or minus 3.
Correct.
According to 24 to 30.
Yeah. 24 to 28. 24 to 28 is what you're expecting in this patient, correct?
Okay, sir. Okay.
So here it is 29, isn't it? 24 to 28 is what is expected, isn't it? So here it is 29.
Okay, sir. Fine. Thank you, sir.
If you're saying 30, then it is normal. If it is 24 to 29 is what you're expecting. 24 to 28 is what is expected.
Okay, sir. Thank you.
Okay, so the cause for the metabolic acidosis possibly, yes. Sorry, the cause for the metabolic acidosis could be renal failure. Yes, this patient has diarrhea going on for that. It could be the respiratory problem in this patients could be due to a COVID related things, but that would be predominantly respiratory. Okay, it wouldn't be metabolic. That could be there. That could be there. Chloride levels are high. Yes, chloride levels are high here. So it is a hyperchloremic normal anion gap acidosis. That's what your final diagnosis would be. Okay. Why the slides are not moving. Okay, so normal anion gap acidosis that you're seeing here. And based on this one, it's an extra renal cause because it is a GI loss that is causing that. Probably secondary to diarrhea. Some amount of lactate could have been there, but that would have caused a high anion gap acidosis that could be seen. Yes, what about this patient here?
Metabolic acidosis again.
Metabolic acidosis. Why do you say so?
pH is less than 7.4.
Yes, and you have the HCO3 is also low. Okay, compensated, yes. Uncompensated?
Partially compensated.
Why do you say it's partially compensated?
Because PCO2 has fallen from 40, but pH is still not like it is still 7.3.
Okay, 7.3. So you're saying it's partially compensation. Okay, you expect the pH to, okay, you're expecting the PCO2 that is there here should be around, okay, as that last time's calculation was 20 up to 30. So this would have been a little more than 30 should have been there. This is at 30. It looks like it is compensated there. Okay, what else are you finding? There is hyperkalemia. Very important. Hyperkalemia and creatinine is raised. Creatinine raised and hyperkalemia, it's there. So what sort of acidosis is this?
High anion gap.
It's a high anion gap acidosis that you're seeing, a metabolic acidosis, which has got compensated here. It's a chronic or it's going on there. So possibly the patient had diarrhea. Again, the history is same here, diarrhea. Possibly it is a pre-renal AKI that could be there. And the breathlessness secondary to metabolic acidosis that you're seeing. So acidotic, it's a metabolic, it's a simple metabolic acidosis that is there, adequate. It's a high anion gap that you're seeing there, and it is probably secondary to renal failure. Okay, so that is what you're able to make out with this. Okay, we can go on to one more. After that, I'll end up. So here we have a female who has come with breathlessness, and she had cholecystitis, and this is her ABG that you're seeing. Yes, what's your So you have pH of 7.3, which is on the lower side there. The PCO2 is very, very low, 12, isn't it? So PCO2 is very low, bicarb is also very low. So when you have both are going on one side, that means there is two disorders that are going in there. So that means there is a combination of an acidosis, and the other one is
respiratory alkalosis.
Respiratory alkalosis, correct. So why does she have these two? Why does she have metabolic acidosis? Why does she have respiratory alkalosis?
Metabolic acidosis due to sepsis.
Okay, metabolic acidosis could be due to sepsis. There is mild renal failure also. Here, if you see the anion gap, what's anion gap here? 140 minus 105. So it is increased anion gap, isn't it? So high anion gap. So you can say renal failure as a cause or a sepsis lactate. Why the respiratory alkalosis? Why the respiratory alkalosis?
CO2 washout due to breathlessness, hyper.
Okay. Could be due to pain. That could be one cause. Pain that could be there. Any other causes? Could be compensated, but compensation should have had its both. So it's an overcompensation that's happened here. So possibly she has, yes, both lactic acidosis and respiratory alkalosis. It could be due to pain. It could be due to respiratory complications that she could have set in. Okay. The other common ABG, I don't think so. I have it in my set here. It is about COPD with a common patient with COPD that you would get, and that is what they ask about. And how do you manage a patient who has COPD with the PCO2 of maybe 60? Patient is in altered sensorium and the PCO2 is 60. How will you manage?
NIV.
Okay, if the patient is conscious, you can try NIV.
Conscious NIV or else intubation.
If it is unconscious or the altered sensorium is there, you would straight put them on invasive ventilation. Mechanical invasive ventilation. If the patient is conscious, definitely you can try NIV. So that's a very common thing that you have to know about. Okay, so I think with that have covered most of the OSCEs. I think in the last 4 sessions we have covered most of it. I hope so. Most of the questions would appear at least in the same format. Any other doubts or any clarifications regarding any other sections?
Sir, why we measure the transverse diameter in Montauk's?
There is nothing specific as why should we measure the transverse diameter. You can measure the maximum diameter wherever the induration is. The maximum induration has to be measured. Now, when we give the test dose itself, generally we make it as a round only. So the maximum diameter has to be measured. There is nothing like transverse diameter alone. Wherever the maximum induration is, you're supposed to measure that. Nothing like transverse. That's to the best of my knowledge. I'm not very sure whether there's something else, but to the best of my knowledge, I feel it is the maximum diameter, not the transverse.
Sir, please put a session on the recent advances in the medicine.
Recent advances is a very, very vast topic. Anyways, okay, let's see. We'll try to do that, but then it's a very vast topic. It doesn't, you have advances in every topic that is there. Okay, let's see if I have the time and I'm able to cover, I will take it up.
So there are no queries on the YouTube live chat?
Fine. Then I think we'll wind up. Thank you. Best of luck.
Thank you so much,
Thank you,
sir.
sir.
Thank you, sir.
Sessions with you are really, really useful for all of us. And a sincere thanks to all the participants who are actively involved in the discussion.
Thank you so much, sir.
Thank you, sir.